Hi everyone, how are you all today? All fine? Today we are discussing about direct pulp capping. Are you all ready? Let's start. Okay, so what is direct pulp capping? Direct pulp capping is a vital pulp therapy procedure in which the exposed vital pulp is covered with a protective dressing or a base over the site of exposure in an attempt to preserve the pulp vitality. So, what are the aims of direct pulp capping? It is to maintain the pulp vitality. And the second important point is to induce the formation of protective hard tissue barrier. So, can we go for direct pulp capping in all the cases? No, it's not possible. So, what are the indications of direct pulp capping? The most important point is the tool should be asymptomatic. So, what does it mean? There should not be any history of spontaneous pain. There should not be any tenderness on percussion. On thermal testing, the two should show normal response. On radiographic evaluation, there should not be any periapical changes. The second important point is the size of the exposure site. It should be minimal, less than 0.5 mm diameter. Also, the hemorrhage from the exposure site should be controllable. That is, the bleeding should be arrested within 10 minutes time. The most important point is the exposure site should be clean and uncontaminated. The last point is atraumatic exposure with a little desiccation of tube with no evidence of aspiration of blood into the dentine. So, once a pulp exposure occurred with above indicated criteria, so what should we do? Under local anesthesia and rubber dam isolation, the bleeding is arrested. And once the bleeding is arrested, the direct pulp capping agent is placed over the exposure site and over which a base is placed. Either can be a glass ionomer cement or a resin modified glass ionomer cement, and over which a final restoration is placed with a bonded composite or amalgam. The well sealed restoration is very important for a good prognosis of direct pulp capping. So here you can see a caries approximating the healthy pulp. So after pulp exposure, the direct pulp capping agent is placed, either calcium hydroxide or MTA or biodentine, and over which a layer of a base of glass ionomer cement or resin modified glass ionomer cement is used, and above which the final filling is done, either with a bonded composite or a amalgam. So what are the direct pulp capping agents that are used? There are so many direct pulp capping agents, starting from gold foil, zinc oxide eugenol, corticosteroids and antibiotics, calcium hydroxide, calcium phosphate, MTA, biodentine, laser, growth factors, enzymes, propolis. So this direct pulp capping agent alone is a vast topic that I will be dealing in the future blog, and also some major topics like calcium hydroxide, MTA, biodentine. This will be also discussed as a separate topics in my future vlogs. So why there is failure in direct pulp capping? The reason might be uncontaminated exposure site, or the second reason might be an improper seal. So what are the factors that affects the prognosis of direct pulp capping? The caries pulp exposure might be prone to inflammation and necrosis. So hence mechanical pulp exposure has a better prognosis than the caries pulp exposure. The another factor is the size of the pulp exposure. So larger pulp exposure has a lesser healing potential than the smaller pulp exposure. The time gap is also important. Once a pulp exposure occurs, the restoration should be done immediately. The another factor is the bacterial contamination. To avoid contamination of the exposed pulp, the rubber dam isolation is mandatory. Thank you for watching this video. Hope you all enjoyed this video. See you all soon with the next interesting topic.